Welcome to today's Explainer. We're taking a deep, multidisciplinary look at osteoporosis, translating some really dense science into a connected, systemic story. Are you a food technologist formulating fortified diets, a clinical physician managing patient care, or maybe a toxicologist studying chemical exposures? Well, this Explainer is designed exactly for you. We're looking at bone health as a massive interconnected puzzle. Let's get right into it.
Let's kick things off with a number that'll immediately grab the attention of our public health scientists: $13.8 billion. That staggering figure was the annual cost of osteoporosis and related fractures in the United States alone. And get this, that was back in 1995. Today we're dealing with a silent epidemic affecting over 200 million people globally. To put that into perspective, 30% of all postmenopausal women in the US and Europe have this disease. This isn't just a geriatric issue, right? It is a major public health crisis that starts decades before the first fracture even happens.
Okay, here is our roadmap for today. We'll be looking at 1. The silent bone epidemic. 2. Cellular remodeling and pathophysiology. 3. Genetics and clinical diagnostics. 4. Nutritional science of bones. 5. Trace elements and biochemistry. And finally, 6. Pharmacology and toxic exposures.
Section 1. The silent bone epidemic. Distinguishing the diagnostics.
We call this disease silent because it progresses gradually, completely without symptoms, until suddenly a fracture occurs. For our clinicians and endocrinologists tuning in, the clinical distinction here is absolutely vital. Osteopenia is a thinning of bone mass, often because of missing nutrients like calcium, vitamin D, or magnesium. It's a huge risk factor. Osteoporosis, on the other hand, marks a critical decrease in bone mass. The bones become so fragile they can fracture with minimal trauma. But here's the fascinating part. In osteoporosis, the chemical composition of whatever bone is left is entirely normal. The calcium to protein ratio doesn't change at all. That is exactly how we distinguish it from osteomalacia, where the bone mineralization itself is flawed.
Section 2. Cellular remodeling and pathophysiology. The brick wall analogy.
Let's zoom in and see how this actually works at the microscopic level. How does a healthy skeleton turn porous? Biochemists think of the skeleton as a brick wall where individual bricks are continuously being pulled out and replaced. Discrete sections of bone are dismantled by bone-resorbing cells. We call those osteoclasts. Then bone-forming cells, the osteoblasts, come in and lay down brand new bone. In a normal adult, this whole remodeling sequence takes about 4 to 5 months. It's a perfect balance. But in osteoporosis, that delicate balance goes completely off the rails. And for the biochemist tracking this, you can look at specific markers. Tartrate-resistant acid phosphatase, or TRAP, shows us osteoclast activity, while circulating osteocalcin is your marker for new osteoblast formation.
So looking at this flowchart, the crucial piece is the systemic feedback loop regulating calcium in our blood. When your dietary calcium or vitamin D drops, your serum calcium drops right along with it. This triggers the parathyroid gland to secrete parathyroid hormone, or PTH. PTH goes directly to the bone, stimulating those osteoclasts to break down bone and release calcium back into the blood. Now look closely at the estrogen receptor. Estrogen acts as the essential brake here. It stops the PTH action. This is exactly why postmenopausal women who experience a sharp drop in estrogen undergo an accelerated rate of bone loss. We're talking up to 3% every single year.
Section 3. Genetics and clinical diagnostics. Measuring the loss.
Let's shift gears to how geneticists and clinical physicians measure this metabolic balancing act. Heredity plays a massive role here. In fact, did you know researchers found an 18-year-old patient in Nebraska with 50% greater bone mineral density than average? Yes, literally 50%. Geneticists traced her family tree and found 17 members with exceptionally dense, completely fracture-free bones. They managed to localize this incredible high bone mass trait to chromosome 11q1213. A systematic search uncovered a specific amino acid change in the LRP5 gene. This mutation confirms there is a unique estrogenic activity in bone remodeling. People are calling it nature's cure for osteoporosis, and it provides an absolutely fascinating genetic blueprint for future pharmacology therapies.
When interpreting DEXA scans, clinical physicians have to use the right diagnostic benchmarks. We use T-scores for men over 50 and postmenopausal women. The T-score compares the patient to the mean value of healthy young adults. But actually, scratch that. For younger patients, we must rely on Z-scores for children and young adults to get an accurate picture. This compares them to a matched population for age, sex, and ethnicity. According to the World Health Organization, if a score is more than 2.5 standard deviations below the mean, that officially confirms osteoporosis.
Section 4.
Nutritional science of bones, feeding the skeleton. We're panning out now to nutritional science, which is absolutely crucial for our dietitians and food technologists. You see, bone health is often called a pediatric disease with a geriatric outcome, mostly because of our early dietary habits. Let's look at the critical, yet sometimes overlooked, role of vitamins beyond just vitamin D. Notice the impact of vitamin C here. Impaired collagen synthesis can literally cause osteoporosis because collagen fibers need to integrate with minerals when bone is formed. The literature actually details a 54-year-old woman diagnosed with severe osteoporosis who, it turned out, had frank scurvy. Her inability to hydroxylate proline resulted in defective collagen. Giving her 500 milligrams of ascorbic acid daily completely arrested her condition. Isn't that wild? Furthermore, for our dietitians, vitamin K is vital for the carboxylation of osteocalcin. High intakes of vitamin K are linked to a 65% lower risk of hip fractures.
For food technologists formulating diets, balancing these factors is key. Did you know that regular consumers of cola-based sodas have about 4% lower bone mineral density? The phosphoric acid in those drinks directly interferes with calcium utilization. Caffeine actively inhibits calcium absorption and bumps up urinary excretion. On the flip side, lactose beneficially assists calcium uptake. And for the nutritionists looking at overall dietary patterns, vegetarian diets actually result in less acidic urine. Since they contain fewer sulfur-containing amino acids than heavy meat diets, they reduce urinary calcium loss, offering a nice protective effect for the skeleton.
Section 5. Trace Elements and Biochemistry, the Micronutrient Engines.
Let's delve into the specific trace elements that keep our cellular machinery humming. Analytical chemists know that trace elements aren't just passive structural components. Take boron, for instance. One study showed that adding just 3 milligrams a day to a boron-deprived diet dramatically elevated 17-beta-estradiol. That's our most biologically active native estrogen. It also bumped up testosterone, which significantly slows down urinary calcium loss. Then we have silicon, which is strictly concentrated in the bone-forming osteoblasts and absolutely required for collagen biosynthesis. And fascinatingly, a manganese deficiency inhibits both osteoblast and osteoclast activity. When deficient, your body will actually dissolve bone just to supply manganese, paradoxically elevating your serum calcium levels in the process.
Section 6. Pharmacology and Toxic Exposures. Disrupting the Cycle.
Finally, let's zoom out to see how exogenous exposures, things from the outside, alter these fragile cellular mechanics. Toxicologists and clinical pharmacists have to carefully monitor patients on certain therapies. For example, giving more than 20,000 units a day of heparin for 6 months or more, that causes severe bone loss. Similarly, selective serotonin reuptake inhibitors, or SSRIs, actually reduce bone mineral density. This happens because circulating serotonin has an inverse relationship with bone mass. We also see massive disruption in organ transplant patients. Up to 65% of liver transplant recipients develop osteoporosis post-transplant. On top of that, chronic alcohol consumption is directly toxic to osteoblasts, and smoking is an independent risk factor that inhibits osteoblast activity. All these exposures inadvertently tip the scales entirely toward osteoclast bone resorption.
But hey, it is not all bad news from the pharmacy. Surprisingly, statins, the common cholesterol-lowering drugs, have actually been shown to increase new bone formation, both in human cells in the lab and in rodent models. Population-based studies in women aged 60 and older show that statins actually protect against non-pathological fractures. If pharmacologists can fully figure out and harness this mechanism, it offers a highly promising, totally unexpected treatment option for osteoporosis that goes way beyond traditional hormone therapies. So, as we wrap up, we have to ask, how will your specific discipline help solve the complex, systemic puzzle of osteoporosis? The balance between osteoblasts and osteoclasts is influenced by everything. From the LRP5 gene, to dietary phosphoric acid in your soda, to trace elements like boron, all the way to pharmaceuticals like SSRIs and statins. Bone health is a highly interconnected ecosystem. The real question is, armed with this multidisciplinary data, how will your specific expertise help tip the scales back toward a healthy skeleton? Thank you so much for joining me on this explainer.